I'm going to start the ball rolling by focusing on a paper Professor Varmus wrote 25 years ago in the New England Journal of Medicine, in which he talked about the challenges of doing globally important research funded by high-income countries, but trials being conducted in other countries. And you heard about HPV questions, for example, when Mr. Trivedi asked the question, he talked about HPV vaccines. And yesterday we spoke about how medical problems are global in nature. Very often the cutting edge technologies to be tested across the world may come from high income areas, and this can become quite challenging. Without trying to take away what he said in that paper, I would like to go back to him to hear about what he sees as the challenges of spread of knowledge, clinical trials funded, for example, during his tenure, NIH onwards across the globe, and what are the basic principles by which such work can receive global cooperation, and what are the challenges he has seen and how we can overcome them. To you, Dr. Varmus.
Well, I'm not sure it's appropriate to begin this panel discussion with me. I'm tired of talking, and you're tired of listening to me. We want to get on to hear from the panelists. But I'd just say briefly that the concern raised in that paper 25 years ago was the extent to which populations of patients who are being included in clinical trials should be incorporated into the planning process, and how investigators from wealthy countries who come to poorer parts of the world to do experiments should be taught to make clinical trials in poorer countries ethically sound. I think a lot has happened in the last 25 years to change the way clinical trials are conducted. There's more engagement with patient populations. Global health has become a science that has become an arena in which science is carried out in a way that I think has a much stronger legal framework. I think anybody who does clinical research in a wealthy country by working with patients in a poor country understands that clinical trials which place human patients at risk should be carefully discussed and planned in collaboration with the host country, with the regulatory bodies, with the physicians and scientists in the host country, and with the patient populations for whom appropriate consent is required. And consent forms, consent procedures are still a matter of dispute in the U.S. We haven't solved all these problems because in any context in which clinical research is being done, there's always some element of risk. Often it's quite minimal, but sometimes it's appreciable. And that has to be balanced with the benefits of doing this research and learning what kinds of preventive or therapeutic strategies are appropriate and safe, effective and safe. So these are complex problems which I think can't be reduced to thinking about oppression of poor countries by rich countries. And I think we've made a lot of progress in trying to figure out how to do that.
Thank you very much. Professor Guleria, as director of AIMS, you have overseen the conduct of multiple clinical trials. As a major premier Indian institution director, how did you prioritize looking at these elements, getting the principles right or getting buy-in locally, making sure that such projects have a local Indian leadership and stakeholdership, and balancing trials in which there could be far-reaching in the future versus those that may have immediate but smaller impact now, given the typical resources, everything else that you have to look at as a leader. So I want to get a bit of your perspective on how you looked at these things, particularly with the National Cancer Institute, everything else being started.
So thank you, and thank you for inviting me. I think what you said is very important. And when you look at research, it's not only promoting research which is important for the researcher, but how are you promoting it to answer relevant questions which are relevant to your own society or your own area. But as was mentioned, it's also important that it should build an environment where technology is there to carry it forward for subsequent researchers. Often a lot of research projects get started which are collaborative, where in countries like the developing world, you are more involved in giving the sample or having the population there rather than developing the technology. And that, I think, was something that happened and has, say, I would say 2-3 decades ago. A lot of samples would be sent abroad for testing, and the research would be done here, but the translation element was not there. So I think the first important question is that you should say that whatever research is done, it should have a long-term implication in terms of developing a lab, in terms of developing a research facility, which could answer subsequent questions. And that's why I think when you look at research questions, you should see how is it going to be useful, not only from the research point of view, but developing a research environment in the institute. So example, we had our own CCRF, the Common Central Research Facility, because the cost of research has also gone up with new technology coming in. So how do you develop a common research facility where researchers can share the equipment and also learn new technologies, but not having to have that much of an investment? So that was done as part of the ongoing process. It was also seen that how can you develop projects which are sustainable and carried forward in terms of research, rather than just sort of stopping at that point in time. And I think the third element which I think is important is the translational element. Very often research actually stops by just publishing a paper. You know, you say you got a good paper with a high impact factor, you've got your PhD and that's it. How do you look at it moving forward into entrepreneurship, into something new that can be done? Encouraging your researchers to really start up or have a startup or do research which is useful from the society point of view rather than just a publication point of view. So developing an ecosystem of having an IPR policy, having certain strategies in the institute which encourage research which can go to a translation element, I think is also very, very important.
Thank you very much. Dipali, this brings me to your side because Dr. Guleria mentioned a very important thing about once upon a time almost every sample had to be sent out because molecular genetics, for example, was simply not available, at least in medical hospitals. You as a molecular pathologist have been looking at doing such stuff in India, which also creates an internal responsibility for people who are clinicians but doing molecular pathology to support such kind of work, but also balance it amongst the routine things that are widely available to the entire population. So as Dr. Guleria put it, resource building to enable local research, and Dr. Varmus said one thing very, very important, the genetic patents got opened up because of the Supreme Court of United States judgment, allowing us to do such work even at clinical scale and services. So how do you balance this in your lab, trying to find that right balance between research, routine clinical services that you must also maintain, and making sure that latest generation technologies become adopted so such work can be done in India?
Thank you very much for the question, and thank you for inviting me here. So just to introduce myself, I'm a pathologist and my prime focus is on lung cancer. And I worked mostly with Dr. Guleria also at AIIMS. So we started with the predictive biomarker testing because this is the immediate patient care when patient's first line treatment starts with the, based on the testing of molecular results. So as you said, it is really challenging for us as a clinical researcher because, and keeping a pace with rapidly evolving technologies and technical platforms, NGS, ddPCR, etc. So those are evolving technologies. Nevertheless, they are essential in precision oncology. So what I do is that for, where the immediate patient care is concerned, I use widely available technologies which are well standardized and validated already. And I seek institute funding for the immediate patient care, but for the evolving technologies like using cell-free nucleic acids from blood of the patients or body fluid of patients, using exome analysis or things like that, those evolving things I keep on research mode. Through the research funding, either individual projects or collaborative grants, I kind of validate and standardized in a research mode before integrating into the clinical practice. And for that, to run those, as you said, AIIMS has an infra, but to run these services in a long run we need a manpower and then constant support to run these technical platforms. We need support from government funding agencies. So that's how I run, using widely available techniques which are validated for immediate patient care versus research technologies I see government funding. And it is very challenging. I mean, I would say that not only in India, there are a lot of global barriers which I feel, people are not aware. Not only people, physicians, if you see in peripheral part of India, physicians also are not aware what tests I should order after, diagnosis of lung cancer or other cancers. So awareness is very important. That's the one and very important barrier which I feel in clinical research if we talk about cancer. And then if they are aware, there is a problem of accessibility, there is a problem of availability of the test. And even if they are aware, even if there is an accessibility, there is a problem of affordability. And it is not just India-centric problem. This I have seen all over the world. People are kind of working on these barriers, and they are kind of making task force to DEI, that is diversity, equity, and inclusion. So therefore, people or part of the country which are underprivileged or liable to be discriminated, they are kind of providing this conceptual framework of DEI task force. And I think that's very important to minimize these global barriers in cancer clinical research and diagnosis.
Very well said regarding the perspective of a clinician researcher providing services as well as building and implementing technologies. We move to Pallavi's point of view as a translational researcher. Very often these technologies will not come readily available, and research institutes may be the ones that may have to first start with the relevant biobanks, large international projects. And very often, Pallavi, you have to span the interface between clinicians and basic scientists, because the technologies may be just so novel that clinical hospitals have not gained access to them. But the samples on which you need to test, the collaborators you need across the world are scattered. How do you approach this problem of creating the large international collaborations, balancing clinical researchers in India and basic researchers? And you have tremendous experience because the cohort that you work with, not cancer, but I think still very relevant.
So, rightly said, I've been trained in basic biology, and for me it was the first transition into translational research was to meet the clinicians. Not for samples. What samples do you have really puts them off. The point is, first you need to understand what is the problem they are facing. Now when they talk about an observation which they have, we need to develop the research questions with them. Now, why we need to do that? Because they have told us that these are resources, these are the clinical samples, this is my observation. Now, research question can be built up by methodology also, if you have the right tools. If you don't have the right tools, you can't build the research questions. So, in case what you talked about, so that we have the right the technology. Now, how do we try to fit in that technology? Like Sir said, you have a question, but the technology isn't come yet. So now in this era, we can't say that, because seriously speaking, there's a lot of technology which is floating, right from deep sequencing, which is not only used for developing new genes or basically identifying new genes that could be potential targets, but also the combinatorial chemistry, which is also on the side of drug discovery. So I would say three things. One is that we need to meet up with the clinicians, and I think the leaderships are really working on this. The funding bodies are working on this because they are asking for collaborative projects. So in the collaborative projects, it's a multidisciplinary project where you have a clinician on board, plus you have a basic biology. And now coming to the translational part of it, just publishing doesn't really hold through. So now the funding body is also coming up with bioincubators, where you can take, see, everybody has to do their work. So clinicians give us a problem, then they sit with us for the research questions. We come up with some answers, but that answers coming back to the society would be with the help of clinical trials and incubators, because it has to be cost effective. Because using technologies in the biology field, it's a lot costly also. Sustainability is not there. So bioincubators find that way where you can take these answers of yours to the society. So that is what I would suggest as translation.
I'm going to push you a little bit more on that. You indicated that, for example, technologies these days are usually available. Of course, one can always imagine questions for which the technologies are yet to come. But more importantly, you will often find a situation where technology does exist, but it's not in India. And at THSTI, you have built global collaboration frameworks, Gavi, WHO, everything. How do you sometimes deal with that issue? For example, something as simple as cellular immunity during the COVID pandemic. Many assays, while there was competence with some exposure, the entire thing had not been put together, so you have to look globally for partnerships. How do you approach that? And because I know you do, how does that work for you?
So I'll give you some few examples, and thanks for putting that example of COVID. So first thing is, now with the era of COVID, one thing good has happened is virtual. So there are so many virtual meetings, and that really helped THSTI at least to understand what is the missing link in the technology and try to build capacity. So there are platforms which have been built in THSTI right now. So if you say about COVID, there are neutralization assays or virus isolation protocols which were shared, not only shared in India but also globally. So technology can come to you, but you need to have the passion to learn it and also follow it up till the end of it. In the sense, you need to develop it and establish it so that it can be for the betterment of the society.
Thank you. And as you can see, Kasturi, to you, we are following a gradient from Dr. Guleria to you of going more clinical to more basic. The question to you is, if you look at Dr. Varmus' talk, you can see it started with fundamental discovery. And towards the end, we were talking of tyrosine kinase inhibitors and mutations. So as a basic researcher with interest in cancer, in your case, for example, cancer metabolism, how do you position your research in the global context of a demand for translation, yet curiosity-driven inquiry, and the fact that you can only ask those questions that you have some tools to start answering? How do you look at it?
All right, thank you, Anurag, for that question, and thanks for letting us sit in a way that it becomes an automatic transition from clinicians to a very basic scientist like myself. So what we do in the lab is trying to identify elements from as many others though, trying to identify the elements that can be translated from our own basic science, which is, for example, our recent discovery has been isolating or identifying and isolating a particular subpopulation of stem cells which are more primed for carcinogenesis, and we call it mitochondria primed stem cells because we realize those carry certain particular properties of mitochondria. So now our obvious question will be to see if they exist in patient, right? So then we would reach out to the clinicians to get samples and try to use our methods that we develop to isolate the primed stem cells subpopulation and see whether they are really what we have seen in our basic studies. But there has been barriers. My experience of barrier and successes is from the US, where I started my lab, and I've moved here very recently. But then, not to be cynical, there have been barriers as well as there have been opportunities. So I was in a med school setup. I could actually reach out to the clinicians very easily. But it took a whole lot of dialogue and time and patience on both our sides to understand each other. We speak different lingo. Clinicians, not to speak of the MD PhDs here, who get to see both sides, but then clinicians who've never done a PhD, we'd speak different lingo, and that took a whole lot of time and patience. Even after you've been able to convince the clinicians that we want your samples, I could not get them engaged to design a study where we will have equal stake. So the stake became only on my side. If it succeeds, it's we'll progress. But if it fails, it's my responsibility. But still, we went ahead and got pilot funding, and then we did some research, some studies with those pilot funding, and now you got to expand on that. And now I have to convince a wider body of clinicians, right? And there, it was sometimes embarrassing to really learn that how different we are, like the clinicians and the fundamental scientists, and the urge of somebody like Pallavi here, if we had proper, training grounds to train people who would understand both sides more or less equally well, not to the extent of being an expert, that would have facilitated the process and made maybe translation easier. I mean, being basic research on one end of the translational spectrum and clinician on the other, and to connect back to, circle it back, bedside to bench to bedside and then back. We need, I think, those people who would liaison well to facilitate and accelerate the process of translation.
Who better to continue the points you raised than a physician scientist, an MD PhD of the type you were talking about?
Well,
Professor
I'm
Varmus.
actually not an MD PhD, but I do want to make 2 points to build on your remarks. First of all, I would like to emphasize the idea that not everybody has to be concerned about translation. It's obvious that the society invests in science for the betterment of the society, and we should be looking for applications of what we do as basic scientists, but not everybody needs to worry about that. And I would argue strenuously that certainly from the perspective of somebody who's working in a highly competitive atmosphere in the US, that this overemphasis, in my view, on translation can suffocate basic research. Everyone feels they've got to do something that's translatable to get funding. And a lot of scientists are turning away from deep problems in basic science that could accelerate progress against disease to do something that they know is going to be immediately investigated in the clinic. I just think that is a wrong attitude. I strongly affiliate myself with your point about how do you get people who are clinically schooled and deeply informed to work on problems that involve basic science. And that best occurs, in my view, when either you have somebody who's trained in a special way, or you get a dialogue to emerge between people of different backgrounds. One of the things that we did when I was at Memorial Sloan Kettering was to create a graduate program that was short of an MD PhD, but it was a program that taught people the basic science of certain diseases. So in this case, the institution developed a program that gave a PhD in cancer biology. So people learned the fundamentals of cancer research. They learned from clinicians on our staff what cancer was like in the clinic. They became the facilitators of translational research, not simply clinical research, which is a special discipline that needs more attention. I suspect here in India, where you don't train as many doctors to become researchers as you might, that there needs to be some emphasis on how a real clinician, someone who's fully schooled as a clinician, can learn the precepts of clinical research. It was a different, the conduct of clinical trials and that kind of thing, a separate discipline of its own. But I think there's also room for people who are in between, who understand at least one disease. They're not full-fledged clinicians, but they are able to pick up the results of fundamental research and apply them to some situation they understand in the clinic.
Thank you very much, Professor Varmus. In fact, the American system in which people without pursuing a formal PhD can do deep research after medical school clearly seems to have helped get to better penetration of such people. One further point I will take up before I go to the room. You said something very interesting, Kasturi, about if the failure is there, it is that of the researcher, while for a pure clinician who may not become a stakeholder in that question. While what you want is both sides to have skin in the game. And Dr. Guleria, I'm going to come back to you on this one, because creating skin in the game on both sides, the clinical side as well as the research side, perhaps is critical. For some physicians who have transitioned to deep basic science as a natural course, it's automatic. But running the system that you did, this must have been challenging, and how did you deal with it?
So I think it is challenging. I mean, I'm a hardcore clinician. I sit from 9 in the morning till 6 in the evening in the outpatient department and see a large number of patients, so, and enjoy that. But research itself has its own sort of satisfaction, and you need to develop a sort of a rapport between the basic science researchers and the clinicians. And as was rightly said, people have a different language. You need to really bridge that sort of gap that exists in trying to understand what the clinician wants and what sort of the clinician cannot give. A researcher may want a lot of things from a clinician, including a performer being properly filled up, the sample being corrected at the proper time, the patients coming regularly. Often in a busy OPD, that does not happen. And you need to develop strategies of how do you move around with that, understanding the issues that a clinician has. So I often say that you should put yourself in the shoes of the clinician. The researcher should put him or herself in the shoes of the clinician and try and understand the issues that the clinician is facing. And the clinician should do the same thing as far as the researcher is concerned and understand what is the need that the researcher feels that is required. And they should also develop an area of facilitation. What we started was a CRU, Clinical Research Unit, at the All Institute of Medical Sciences, which is basically a group of people who are biostatisticians, epidemiologists, and people who help clinicians who have a question, collaborate with others and get the funding for the research, help them in doing the project, and even help them in writing the paper. So the CRU actually supports a clinician in doing research and sort of, if the clinician doesn't have time for all of this, does that, and that I think really helps in a big way. So developing a strategy like that would somehow be useful in having collaboration between the clinician and the researcher.
Professor Varmus.
Just want to comment briefly on that statement, because the US is not so different from India in many ways. And this question of time for clinicians to participate in research is really critical. I'm involved in a project now looking, as I mentioned briefly, looking at cancer genomes in patients from underrepresented minorities who are very frequently treated at incredibly busy non-academic hospitals. And the biggest problem we have in getting this project moving is that the clinicians at these places are working not just from 9 to 6, but maybe from 7 to midnight. They don't have, it's not just not having access to facilities or to interactions with researchers, they lack the time to engage in any kind of research. And I think probably everywhere in the world, for a variety of reasons, and sometimes just blatantly financial, we're unable to provide to people who have an interest in research and are clinicians the time that it takes to do research work, which is very time consuming. So one of the things we've tried to do in the US is to provide certain kinds of training programs for people who have research interests so that they have 1 or 2 days a week when they're not required to work in the clinic. I know it's hard to do that, and we find it hard even in a place like New York to provide the time that's necessary for clinical research to be done or for collaborative research to be done with basic investigators.
So I think the problem in India is that the patient load is so much that most clinicians are, 24/7, either in the outpatient or in the ward, and to ask them to take time out for research becomes very, very difficult. As a matter of fact, a lot of clinicians who actually like to do research probably sacrifice a lot of their family time and would spend a weekend in their office trying to write the paper or trying to collect the data. So I think it's something that we need to develop a strategy of how do we balance this out. But with the patient load, especially in government hospitals, it's very, very difficult to really take time out for pure research.
It reminds me of my laziness and non-willing to work Sundays that made me switch to a purely basic career after coming back.